Make mealtimes pleasant as possible. Put bedpans, emesis basins, and drainage collection devices out of sight. Ventilate the room to reduce odors. Do not schedule tiring activities immediately before meals. Record daily weights as ordered to monitor both nutritional and fluid status. Activity intolerance. Some activity limitations are usually imposed, depending on the patient's overall status. Schedule nursing care to allow some periods of undisturbed rest. The patient can generally assume any position that is comfortable. If the patient spends all or most of the day in bed, there is a risk of complications related to immobility. Patient teaching cirrhosis a balanced diet will help to prevent additional injury to the liver and reduce the risk of complications. Avoid specific foods, as advised by the physician, the dietitian, or both. Notify your physician if you have increasing fluid retention, black tarry stools, bloody vomitus, increasing fatigue, or confusion. Alcohol is discouraged because of the toxic effects on the liver. Community resources you can use for information and assistance include Alcoholics Anonymous, if appropriate, the American Liver Foundation, and home health nursing services. Do not take medications except as approved by your physician. Many drugs, including acetaminophen, can be harmful to the liver. Risk for impaired skin integrity. The patient with cirrhosis is at risk for skin breakdown for several reasons. Bile salts that are normally processed by the liver may be deposited under the skin, causing intense pruritus. Loss of muscle and fat tissue with advanced disease reduces the padding that normally protects the skin from pressure. Also, many patients have edema, which makes tissue more fragile and impairs healing. Nursing measures to relieve the itching of pruritus include gentle bathing with mild soap and tepid water, thorough rinsing, and application of moisturizing lotions. The patient's nails should be kept short to reduce trauma from scratching. If scratching persists, put soft cotton mittens or gloves on the patient's hands. If itching is severe, consult the physician about ordering a medication to relieve the discomfort. Cholestyramine, Questran, may be ordered to increase the excretion of bile salts. Ineffective breathing pattern. Acidic fluid can cause the abdomen to become greatly distended. While in bed, the patient breathes easier with the head of the bed elevated. Sitting in a chair with the feet elevated, if allowed, may be even more comfortable. Risk for injury. The patient with cirrhosis is at great risk for injury or hemorrhage due to impaired coagulation and fragile varices. Handle the patient gently to avoid trauma. Use a soft toothbrush or swab for mouth care. Apply firm pressure to injection sites to minimize oozing. Pad side rails if the patient is restless. An uncommon but effective treatment for bleeding esophageal varices is an esophageal gastric balloon tube placement. The patient with this type of tube is usually in an intensive care unit since close monitoring is necessary. The tube is uncomfortable, and the patient is likely to be frightened about both the bleeding and the treatment. When the tube is in place, monitor the patient for signs of continued or renewed bleeding, including restlessness, increasing pulse and respirations, and falling blood pressure. Note stool characteristics. Bleeding from esophagus or stomach usually produces a sticky, tarry, maroon to black stool. Examine aspirated stomach and esophageal contents for evidence of fresh bleeding. Old blood in the stomach is usually brownish and may be described as resembling coffee grounds. Fresh blood is bright to dark red. Because the esophagus and the trachea are adjacent to each other, upward movement of the esophageal balloon can cause airway obstruction. Therefore, when the balloon tube is in place, monitor the patient for sudden respiratory distress. If this occurs, both balloon ports must be cut promptly, and the tubes removed by a properly trained person. Acute confusion. Cognitive changes in the patient with cirrhosis are usually due to hepatic encephalopathy. Nursing care of the patient with hepatic encephalopathy includes monitoring mental and neurologic status. Inform the R or physician of changes in status. The patient who is confused or unconscious requires close attention to prevent injury or complications of immobility. Talk to the patient to provide basic information and reassurance. The family also may need an explanation of the patient's behavior. Administer prescribed drugs that decrease ammonia-producing bacteria in the intestines, example, lactulose. Be alert for adverse effects of drug therapy, which may include diarrhea or vitamin K deficiency. Deficient fluid volume or excess fluid volume. Fluid needs vary with the patient's condition. Sodium and water are likely to be restricted if marked edema or ascites exist. Despite the excess in total body water, the patient's blood volume may be dangerously low. Adequate water is present, but it is not distributed appropriately. Without adequate albumin in the serum, colloid osmotic pressure falls, and water shifts out of the capillaries into the tissues. Administer intravenous fluids and albumin 25% as ordered. In addition to monitoring vital signs, evaluate fluid intake and output. Risk for infection. The patient with cirrhosis is at risk for infection for several reasons. The liver is no longer able to filter bacteria from the blood as it comes from the intestines. The function of the spleen also is impaired, which lowers resistance to infection. In addition, these patients tend to be malnourished, so they lack the building materials necessary for tissue repair. Monitor for fever and malaise, which suggest infection. Protect the patient from others with infections. Practice good hand washing and use aseptic technique for invasive procedures. Fear. Patients with cirrhosis can experience frightening complications, including confusion, dyspnea, and hemorrhage. With advanced cirrhosis, the prognosis is poor, and patients often have repeated emergency admissions. Treatments and diagnostic procedures may be painful and anxiety-producing. The nurse can help by recognizing the patient's fear and acknowledging it. To provide emotional support to cirrhosis patients, you must be aware of your personal reaction to these patients. There is a stigma attached to cirrhosis because it is often associated with alcohol abuse. Healthcare providers must treat patients in a non-judgmental manner. Nurses must realize that alcoholism is a complex chronic disease that is not easily controlled, and that cirrhosis can be caused by factors other than alcohol. Information can help to reduce fear. When the patient is acutely ill, give simple explanations and answer questions. When the patient improves, explore what he or she knows about cirrhosis and determine what additional information is needed. Patient Teaching Box. Cirrhosis. A balanced diet will help prevent additional injury to the liver and reduce risk of complications. Avoid specific food as advised by the physician and the dietitian. Notify your physician if you have increasing fluid retention, black tarry stools, bloody vomitus, increasing fatigue, or confusion. Alcohol is discouraged because of the toxic effects on the liver. Community resources you can use for information and assistance include Alcoholics Anonymous, if appropriate, the American Liver Foundation, and home health nursing services. Do not take medications except as approved by your physician. Many drugs, including acetaminophen, can be toxic to the liver. Discuss liver transplant, A and P of the biliary tract, nursing assessment and diagnostic test and procedures. Liver transplantation. Indication: end-stage liver disease, cancer confined to the liver, and congenital disorders. Donors are living or dead, but if patient doesn't have a living donor that can donate a segment of their liver, then patient has to be put into the National Computer Network and hopefully locate one. Postoperative nursing care. Manage patient's T-tube, wound drainage device, NG tube, central line, for TPN, mechanical ventilation. Monitor patient for signs of organ rejection. Teach patient the S/S of organ rejection, infection, how to do wound care, dietary restrictions, and self-medication. Post-op nursing assessment. Check the neurologic status, vital signs, central venous pressure, respiratory status, indicators of bleeding, intake and output, assist with turning, coughing, deep breathing, and progressive activity. Drug therapy. Patient will take prednisone for 2 weeks to 3 months after surgery. Patient will take lifelong organ rejection prevention drugs like cyclosporin, tacrolimus, monoclonal antibody OKT3, interleukin-2 receptor antagonist, azathioprine. Organ rejection is treated by corticosteroids or immunosuppressant meds. If this fails, the patient will need a retransplantation. Bile. Yellow-green liquid that contains bile salts that are used for emulsification/digestion of fats. Made in liver and excreted via the common hepatic duct. Gives a way for bilirubin to be excreted from the liver. Biliary tract. Consist of the common hepatic duct plus cystic duct equals common bile duct dash gallbladder, sac-like organ that store bile. When fat enters the intestines, gallbladder contracts to push bile out through the common bile duct. Assessment. Health history. Present illness, digestive disturbances, pain, location, onset, intensity, duration, relationship to meals, aggravating/relieving factors. Past medical history, gallbladder disease, pregnancy, surgery, recent and current medications, note oral contraceptives/estrogen. Family history, gallbladder disease, Native Americans ancestry, Caucasian ancestry. Health history, continued. Review of systems, pruritus, fatty intolerance, dyspepsia, nausea/vomiting, light-colored stools, dark urine. Physical examination. Vital signs, tachycardia, tachypnea, fever. Skin, dryness, jaundice. Abdomen, guarding, distension. Diagnostic test. Ultrasonography, oral cholecystography, intravenous cholangiography, T-tube cholangiography, endoscopic retrograde cholangiopancreatography, ERCP, percutaneous transhepatic cholangiography. Laboratory test. Liver function test, serum/urine bilirubin, ALP, ALT, CBC. Discuss cholecystitis and cholelithiasis, nursing care of patient with gallbladder disorder and after cholelithiasis. Discuss patient teaching post-cholecystectomy. Cholecystitis. Cholecystitis is inflammation of the gallbladder. It is caused most often by the presence of gallstones, but can be the result of bacteria, toxic chemicals, tumors, anesthesia, starvation, and opioids. The inflamed gallbladder and cystic duct become swollen and congested with blood. The cystic duct may become occluded. Cholelithiasis. When gallstones are present, the patient is said to have cholelithiasis. Most gallstones are composed of cholesterol mixed with bile salts, bilirubin, calcium, and protein. It is not known exactly why gallstones form, but the process is associated with high concentrations of cholesterol. The concentration of cholesterol rises when stasis of bile exists, as occurs with pregnancy, immobility, and inflammation of the biliary tract. Many patients with gallstones have no symptoms. The condition is often diagnosed incidentally during imaging procedures for unrelated complaints. Gallstones may be found anywhere in the biliary tract, the gallbladder, the cystic duct, or the common bile duct. The stones may move through the biliary tract with bile flow. If a stone cannot pass through the tract, it lodges and causes an obstruction. Ducts respond to obstruction with spasms in an effort to move the stone. This is responsible for an intense, spasmodic pain, called biliary colic. If the cystic duct is obstructed, bile cannot leave the gallbladder and inflammation develops. Cystic duct obstruction does not prevent the flow of bile into the duodenum from the liver. However, if the common bile duct is obstructed, cholelithiasis, bile is unable to flow into the duodenum. Signs and symptoms. Signs and symptoms of cholecystitis vary from one patient to the next. Some have only mild indigestion, whereas others have severe pain, fever, and jaundice. Other symptoms are nausea, eructation, belching, fever, chills, and right upper quadrant pain that radiates to the shoulder. Symptoms typically occur about 3 hours after a meal, especially if the food had high fat content. When bile flow is obstructed, bile production in the liver decreases and the serum bilirubin rises, leading to obstructive jaundice. Some excess bilirubin is excreted in the urine, creating a dark amber color. Digestion of fats is impaired, causing intolerance of fatty foods and steatorrhea, i.e., excess fat in feces. The absence of urobilinogen in the stool causes it to be a characteristic clay color. The patient is unable to absorb fat-soluble vitamins and may show signs of vitamin deficiencies. Vitamin K deficiency interferes with normal blood clotting and thus the patient bleeds and bruises easily. Complications. The most serious complications of cholecystitis and cholelithiasis are pancreatitis, abscesses, cholangitis, i.e., inflammation of the biliary ducts, and rupture of the gallbladder. Medical diagnosis. Ultrasonography usually confirms a tentative diagnosis of cholelithiasis based on patient history and physical examination findings. Other diagnostic procedures include radiographs and radionuclide imaging. A technetium-labeled hepatobiliary immunodiacetic acid (HIDA) scan is a specific test for acute cholecystitis. Blood and urine studies provide additional information. With inflammation or infection, the WBC count is elevated. If bile flow is obstructed, levels of serum and urinary bilirubin and serum enzymes may be elevated. Medical treatment. Acute cholecystitis is managed symptomatically. Analgesics and anticholinergic agents are ordered to relieve pain and muscle spasms. Antibiotics are given to treat infection. Intravenous fluids are selected to maintain fluid balance, especially if the patient has been vomiting. A nasogastric tube may be inserted and attached to suction to rest the bowel. This relieves nausea and vomiting and reduces the stimulation of the gallbladder by intestinal contents. Among the options available for the treatment of cholelithiasis or cholecystolithiasis are drug therapy, shock-wave lithotripsy, endoscopic sphincterotomy, and cholecystectomy. Patients with asymptomatic gallstones usually require no treatment except in special circumstances. Drug therapy. Drugs that dissolve gallstones include bile salts and dissolution agents. Bile salts include chenodeoxycholic acid, Chenodal, and ursodeoxycholic acid, UDCA, Actigol. These drugs may be prescribed when the patient has only small cholesterol stones or for those who are poor surgical risks. However, they are expensive and typically require continuous treatment for as long as 2 years. Some patients require continuous therapy to prevent recurrence. Methyl tertiary butyl ether, MTBE, and ethyl propionate are dissolution agents. MTBE is instilled into the gallbladder through a transhepatic catheter. The physician instills and aspirates the drug repeatedly until fluoroscopy shows that the stones either have dissolved or are not responding to the treatment. Extracorporeal shock wave lithotripsy. Extracorporeal shock wave lithotripsy, ESWL, uses sound waves to break up gallstones in patients with few stones and mild to moderate symptoms. Fragments that remain in the gallbladder are dissolved with UDCA, ursodeoxycholic acid. Gallstones recur in about half of patients successfully treated with ESWL. Laparoscopic cholecystectomy has largely replaced ESWL. Endoscopic sphincterotomy. Endoscopic sphincterotomy involves the use of endoscopic instruments to incise the sphincter body and extract stones from the common bile duct. The patient is given a sedative but remains conscious during the procedure. Lidocaine spray is used to deaden the gag reflex so that the endoscope can be passed through the mouth. A choledicoscope also can be inserted through a T-tube into the common bile duct. A special basket, example, Dormia basket, is used to extract the stones. After endoscopic sphincterotomy, the patient is usually kept on bed rest for 6 to 8 hours. Nothing is given by mouth until the gag reflex returns. The patient is monitored for signs of complications. Bloody stools and tachycardia may indicate hemorrhage secondary to trauma. Fever and abdominal pain may indicate pancreatitis or perforation of the duodenum. Cholecystectomy. Cholecystectomy is the most frequently used treatment for cholelithiasis. The two procedures that may be used are via laparoscopy or through a right subcostal incision. For laparoscopic cholecystectomy, the surgeon inserts a laparoscope with a camera through a small abdominal incision. Using the camera, the surgeon guides forceps and a laser toward the gallbladder through other small abdominal incisions. The gallbladder is grasped with the forceps, cut free with the laser, and pulled out through one of the small incisions. Stones remaining in the common bile duct can be removed endoscopically. The most serious complication, although rare, is injury to the bile duct, which requires endoscopic repair. Patients usually are discharged the same day or on the day after surgery and resume regular activities within a week. In the classic procedure, an incision is made below the right rib margin. The gallbladder is removed, and the common bile duct is explored for stones. Exploration of the bile duct may cause it to swell and obstruct bile flow from the liver. A T-tube may be placed in the common bile duct to maintain bile flow until swelling in the duct subsides. One part of the tubing is brought through the patient's skin and connected to a closed gravity drainage receptacle. Wound drains also may be present. When the patient first returns from surgery, the drainage from the T-tube may be bloody, but it should soon become greenish-brown. Drainage should gradually decrease as edema subsides in the common bile duct. Measure and record the amount of drainage and notify the physician if it exceeds 1,000 milliliters in 24 hours. Place the patient in a low Fowler position with the tube arranged to drain freely. Protect the tube during movement to prevent dislodging it. The physician specifies the level of the drainage bag and when it should be clamped. If the patient experiences pain, fever, chills, nausea, or distension, the tube should be unclamped. The physician removes the T-tube when the patient tolerates clamping for a prolonged period of time. Cleanse the area around wound drains using a septic technique and dress per agency protocol. If the patient is discharged with the T-tube in place, you must teach the patient to care for the tube, including emptying the receptacle, caring for the insertion site, and recognizing when to clamp and unclamp it. Interventions for the patient with a gallbladder disorder. Fluid volume deficit. If nausea and vomiting are present, the patient is at risk for fluid and electrolyte imbalances. Administer antiemetics as ordered. Keep intake and output records. Monitor for signs of deficient fluid volume, hypovolemia, tachycardia, hypotension, dry skin, concentrated urine, decreased urine output. If vomiting is severe, a nasogastric tube may be inserted and attached to suction. Fluids are provided intravenously. Note the amount and characteristics of aspirated fluid. A problem associated with nasogastric decompression is the continuous removal of gastric secretions. When the fluid is continuously drained, the patient loses significant water, electrolytes, and acid. This puts the patient at risk for deficient fluid volume, potassium deficit, sodium excess, and metabolic alkalosis. Serum electrolytes are monitored, and specific intravenous fluids are ordered to maintain or restore balance. Risk for impaired skin integrity. Patients who have obstructive jaundice due to blockage of the bile ducts often have pruritus caused by accumulated bile salts under the skin. Measures to promote comfort include tepid baths with baking soda or oily lotions, use of soft linens, and maintaining a comfortable room temperature. Patients should be advised not to scratch, but that can be difficult. Short fingernails or even cotton gloves may be suggested to avoid skin injury from scratching. The physician may order a drug such as cholestyramine, Questran, to reduce the discomfort. Anxiety. Acute pain and unexpected hospitalization can provoke anxiety for patients and their families. Provide clear explanations about what is being done and what they can expect. Acknowledge their anxiety and take time to answer questions and offer reassurance. Acute pain. The degree of pain with cholecystitis varies, but many patients experience severe pain. Meperidine, Demerol, may be ordered because morphine causes spasms in the common bile duct, which would increase the patient's pain. However, some experts believe that morphine provides better pain control and that spasms can be controlled by giving atropine with morphine. Evaluate comfort often and medicate the patient as soon as pain is reported instead of waiting for it to become severe. When opioid analgesics are given, take safety precautions because the drugs cause drowsiness. In addition to medications, position changes, smooth linens, back rubs, and mouth care to promote comfort. Biliary colic attacks are caused by stimulation of the gallbladder, most often by fats in the duodenum. A low-fat diet is recommended to decrease the incidence of acute symptoms. A patient who has obstructed bile flow may have a deficiency of vitamin K because absorption of this vitamin in the digestive tract requires bile salts. Vitamin K is needed to produce prothrombin, an essential element for clotting. Indications of vitamin K deficiency include bleeding gums and oozing of blood at injection sites. Minimize trauma by using a soft toothbrush or swab for mouth care and by applying gentle pressure to injection sites. Patient teaching for cholelithiasis. You need to have a low-fat diet with supplementary fat-soluble vitamins, or as ordered by the physician. The dietitian will explain the details of the diet to you. Notify your physician of signs of bile duct obstruction, light stools, dark urine, jaundice, and itching. Report. If you are taking bile salts, report gastric upset. Keep medical appointments to have blood drawn to monitor liver function. Do not rely on oral contraceptives. Bile salts interfere with their effectiveness. Nursing care of the patient after surgery for cholelithiasis. Assessment. Postoperatively, take the patient's vital signs until he or she is stable. Observe chest expansion and auscultate breath sounds. Inspect the dressing for bleeding. If a T-tube is present, note the color and amount of drainage. Examine passive drains to ensure that they are functioning properly. Inspect the skin around the incision or the drain for redness or breakdown. If a nasogastric tube is in place, observe the characteristics and amount of the drainage and ensure that the suction is operational. Inspect the patient's nares for irritation or pressure from the tube. Interventions for the patient after surgery for cholelithiasis. Acute pain. When the patient undergoes a procedure that requires a surgical incision, pain is expected. In addition to administering ordered analgesics, reposition the patient for comfort and check to ensure that any drainage tubes are functioning. Show the patient how to support the incision with the hands or a pillow during coughing and deep breathing. If pain continues despite these measures, notify the physician. The patient who has a nasogastric tube in place has an additional source of discomfort. The nose and throat may become very sore. Secure the tube to the patient's upper lip or nose so that it is not moved or tugged easily. Gently cleanse the nares and provide frequent mouth care. Ineffective breathing pattern. Potentially ineffective breathing patterns are most likely to be a problem when the patient has a subcostal incision. The incision is located close to the diaphragm, so full lung expansion is painful. The patient tends to guard the surgical area by not breathing deeply. Explain the importance of deep breathing and coughing to prevent atelectasis and pneumonia. Also demonstrate how splinting the area makes breathing and coughing more comfortable. Adequate pain management enables the patient to breathe more effectively. Monitor respiratory rate and breath sounds. Deficient fluid volume. Postoperatively, measure fluid intake and output. Until oral fluids are permitted, administer intravenous fluids as ordered. Blood studies may be ordered to assess serum electrolytes. If nasogastric suction is ordered, check frequently to ensure that it is working properly. Otherwise, the patient may have distension that causes vomiting and further loss of fluids and electrolytes. Impaired skin integrity. Patients who have subcostal incisions often have wound drains in place. These drains allow for removal of fluids that collect at the surgical site. A Penrose drain diverts fluids directly onto the wound dressings. This requires frequent dressing changes to prevent skin irritation. It is especially important if bile is present in the drainage, because bile contains digestive enzymes, which are even more irritating. A pouch collection device like those used for stomas can be applied if needed to protect the skin. A passive drain, such as the Jackson-Pratt drain, has a fluid collection device that keeps fluid away from the skin. Risk for infection. The patient who has undergone gallbladder surgery is at risk for infection of the surgical wound. Draining wounds provide a moist environment for bacterial growth. Meticulous wound care can reduce that risk. A complication of endoscopic sphincterotomy is pancreatitis caused by accidental injury to the pancreatic duct. Early signs of pancreatitis are pain and fever. Patient teaching for cholecystectomy. After laparoscopic cholecystectomy, usual instructions include the following. Avoid fatty foods for several weeks. Remove the dressings and bathe or shower normally the next day. Notify the physician if redness, drainage, or pus from the incision is noted. Report any signs of peritonitis, severe abdominal pain, chills and fever, and vomiting. A low-fat diet may be recommended for 4 to 6 weeks. In general, avoid heavy lifting for 4 to 6 weeks or as prescribed. Other activities, including sexual intercourse, usually can be resumed when you feel well enough. After incisional cholecystectomy, you may have a T-tube. We will teach you how to care for the T-tube before you go home. Discuss cancer of the gallbladder. Discuss A&P of the pancreas, nursing assessment and diagnostic test. Rare. Thought to be related to chronic cholelithiasis. Diagnosis often delayed. Early signs and symptoms are same as cholecystitis and cholelithiasis. Cholecystectomy is only treatment. Only supportive, symptomatic care is given. Fish-shaped. Located in the left upper quadrant of the abdomen, behind the stomach. Head lies next to the duodenum. Tail lies next to the spleen. One duct goes directly to the duodenum and the other merges with the common bile duct. Carried out by the acinar tissue. Acinar tissue is composed of tiny grape-like clusters of cells that produces pancreatic fluid. Pancreatic fluid contains enzymes needed for the digestion of proteins, fats, and carbohydrates. Enzymes include trypsin, amylase, and lipase act on partially digested foods in the small intestines. Trypsin plays a role in digestion of protein by breaking proteases and peptones into small polypeptides. Normally, trypsin is not activated until it enters the duodenum. Amylase acts with intestinal enzymes to reduce starch, sucrose, and fructose to glucose, fructose, and galactose. Lipase acts on emulsified fats to yield fatty acids, glycerides, and glycerol. Carried out by clusters of specialized cells scattered throughout the pancreas called islets of Langerhans. Islets contain alpha, beta, delta, and PP cells. Alpha cells produce and secrete glucagon. Beta cells produce and secrete insulin. Delta cells produce somatostatin. PP cells secrete pancreatic polypeptides. Glucagon secreted when the glucose level falls. Stimulates the liver to convert glycogen into glucose. Insulin is secreted when the blood glucose level rises. Somatostatin inhibits the release of glucagon and insulin. Polypeptides are a family of peptides known chiefly for their inhibitory functions. Health history. Inquire about the patient's general health status. Past medical history. Medication history. Family history. Complete description of any pain in upper abdomen or epigastric area. Functional assessment. Symptoms. Pancreatic disorders are often accompanied by weakness and fatigue. Past medical history may reveal previous disorders of the biliary tract or duodenum, abdominal trauma or surgery, and metabolic disorders such as diabetes mellitus. Medication history should include use of thiazide diuretics, furosemide, oral contraceptives, corticosteroids, sulfonamides, and NSAIDs. Symptoms: dyspnea, nausea, and vomiting. Note restlessness, flushing, diaphoresis. Vital signs may disclose low-grade fever, tachypnea, tachycardia, and hypotension. Inspect skin for jaundice. Assess abdomen for distension, tenderness, discoloration, and diminished bowel sounds. Done to measure bilirubin, urinary and fecal urobilinogen, serum proteins, ammonia, vitamin K production, prothrombin time, PT, international normalized ratio, INR, and serum enzymes. Because GI bleeding is sometimes a problem with liver disease, gastric fluids and stools may be tested for the presence of occult blood. Urine specimens also may be tested for bilirubin and urobilinogen, and stool specimens tested for urobilinogen. Used primarily to visualize the circulatory and biliary systems in the liver. Includes computed tomography, CT, magnetic resonance imaging, MRI, hepatobiliary scintigraphy, HITA, and abdominal ultrasound. Non-invasive, painless procedures. HITA is a nuclear imaging scan that uses a radioactive substance. After being injected into a vein, the substance accumulates in the liver. Radiographs are then taken to reveal the size, shape, and position of the liver as well as tumors, cirrhosis, and abscesses. Ultrasonography uses sound waves to create an image of the liver, spleen, pancreas, gallbladder, and biliary system. Non-invasive and painless procedure. Used primarily to visualize the circulatory and biliary systems in the liver. Includes computed tomography, CT, magnetic resonance imaging, MRI, hepatobiliary scintigraphy, HITA, and abdominal ultrasound. Non-invasive, painless procedures. HITA is a nuclear imaging scan that uses a radioactive substance. After being injected into a vein, the substance accumulates in the liver. Radiographs are then taken to reveal the size, shape, and position of the liver as well as tumors, cirrhosis, and abscesses. Ultrasonography uses sound waves to create an image of the liver, spleen, pancreas, gallbladder, and biliary system. Non-invasive and painless procedure. Involves the removal of a small specimen of liver tissue for examination. Specimen can be obtained through an incision under general anesthesia, open biopsy, or with the use of a special type of needle inserted through the abdominal wall to obtain the specimen, needle biopsy. Before either procedure, baseline vital signs should be obtained and blood coagulation studies done. The patient's blood should be typed and cross-matched because of the risk of bleeding. Signed consent is required. Tell the patient what to expect during the procedure. For a needle biopsy, position the patient supine with the right arm behind the head. Place a pad under the right chest. The physician instructs the patient to take a deep breath and hold it during the actual puncture. A sample of liver tissue is aspirated for study. Afterward, a pressure dressing is placed over the puncture tissue for examination. Check for bleeding every 15 minutes for the first hour and every 30 minutes for the next hour, then hourly or according to agency protocol.
Monitor vital signs at the same time for signs of blood loss, tachycardia, restlessness, hypotension, or pneumothorax, restlessness, tachypnea.
The physician usually orders the patient kept on the right side for at least 2 hours to maintain pressure on the puncture site. After being allowed to change positions, the patient may still be kept flat for up to 14 hours. Primary complications of liver biopsy are hemorrhage and pneumothorax. Bleeding is a possibility because of the liver's rich blood supply and the potential for impaired coagulation in the patient with liver disease. Pneumothorax occurs if the lung is accidentally punctured during the biopsy. Air escapes into the pleural cavity and the lung on the affected side collapse. General intervention. Check your agency procedure for manual for diagnostic tests and procedures. Always tell the patient what to expect when tests are ordered. Explain if nothing by mouth status is necessary. Document the care provided and relevant assessment data. If venipuncture is done, apply a dressing and check the site oozing. Apply pressure and elevate arm if patient's blood clotting is impaired. Serum bilirubin.
Purpose and procedure, as liver function. Normal valuesare total bilirubin 0, 2, 1, 0 mg/dl 3, 4 minus 17, 1 molele, conjugated bilirubin 0, 0, 0, 2 mg/dl 0, 0, 3, 4 molele, un conjugated bilirubin 0, 2, 0, 8 mg/dl.
Patient preparation. Fast at least 4 hours before blood sample drawn. Avoid yellow for 3 to 4 days before the test. Wait at least 24 hours after a contrast medium has been given. Post-procedure nursing care, NO special care is required. Alkaline phosphatase. Purpose and procedure. Detects elevation associated with the liver or bone disease. Normal value varies with method. Patient preparation, a 10 to 12-hour fast may be required. Some drugs may be withheld for 12 hours. Post-procedure nursing care, no special care is required. Serum enzymes. Alkaline phosphatase, gamma-glutamyl-transpeptidase, GGT, alanine aminotransferase, ALT, also known as serum glutamic pyruvic transaminase, aldolase, aspartate aminotransferase, AST, also known as glutamoxylacetic transaminase, and lactate dehydrogenase, LDH. Purpose and procedure. Detects elevation in enzymes related to liver disease. Normal values vary with gender and age. Patient preparation. Consult agency guidelines to see if fasting is necessary. Some require listing of patient's medication on request form. Post-procedure nursing care, no special care is required. Prothrombin time, PT, and International Normalized Ration, INR. Purpose and procedure: measures clotting ability, may be prolonged due to liver disease, vitamin K deficiency, or anticoagulant therapy. Normal values are PT 11.0 to 14 seconds and INR 1.0 to 1.3. Patient preparation: no coffee or alcohol for 24 hours before the test. Many natural remedies affect the results. Post-procedure nursing care: use pressure and arm elevation if needed to control bleeding at puncture site. Immediately report PT 46 seconds or INR greater than or equal to 5. Serum protein. Purpose and procedure: electrophoresis helps to diagnose condition that affect serum proteins. Patient preparation: avoid a high-fat diet for 8 hours before the test. Some medications may need to be withheld for several days before a blood sample is drawn. Post-procedure nursing care: no special care is required. General intervention when contrast dye used. Before procedure, assess patient allergy dye, iodine, or shellfish. If patient reports allergy, notify radiology. Tell patient that injection of contrast dye can create a warm feeling of warmth, a salty taste, and nausea. After procedure, inform the physician of any signs of allergic response to the contrast dye. Administer antihistamines as ordered for allergy. Computed tomography, CT. Purpose and procedure: CT creates cross-sectional images of the liver and other organs to reveal abnormalities. Contrast dye may be used. The patient lies still on a stretcher while a donut-shaped machine moves around him or her. Contrast dye may be injected intravenously. Patient preparation, dye precautions. Inform the patient that the procedure is painless and non-invasive. NPO status may be ordered, but routine drugs usually can be taken. Sedation can be ordered if the patient has difficulty lying still. Post-procedure nursing care, dye precaution. In most cases, no special care is required. Cholangiography. T-tube, intravenous, percutaneous transhepatic, surgical magnetic resonance cholangiopancreatography. Purpose and procedure: provides images of hepatic and biliary ducts through various procedures. A contrast agent may be injected, and images obtained. The test takes 4 to 6 hours. Patient preparation, dye precautions. Food and fluids should be withheld as ordered. The patient is usually NPO after midnight before the study. A laxative also may be ordered the night before. Post-procedure nursing care, dye precautions. A fatty meal helps to eliminate dye if used. After percutaneous transhepatic cholangiography, watch for signs of bleeding and respiratory distress. Portal venography and hepatic arteriography. Purpose and procedure: the tests use intravenous contrast dye followed by radiographs to study blood vessels in liver. Patient preparation, dye precautions. Post-procedure nursing care, dye precautions. Care is the same as for T-tube cholangiography. Liver scan. Purpose and procedure: a radioactive substance that collects in the liver is given intravenously, and radiographs are taken with the patient in various positions. A scanner maps uptake of radiation, revealing tumors and abscesses. Patient preparation: assess patient that a small dose of radiation is harmless. A fast of 4 to 6 hours is required. Post-procedure nursing care: the patient wash his or her hands thoroughly after voiding for 24 hours. Report any allergic symptoms. Gallbladder scan, hepatobiliary scintigraphy, hepatobiliary imaging, biliary tract radionuclide scan, coloscintigraphy. Purpose and procedure. A radionuclide is injected and images are taken of the biliary tract to assess patency and to detect cholecystitis. Takes about 90 minutes. Repeat imaging may be needed for 24 to 48 hours. Patient preparation, NPO at least 2 hours before the procedure. Post-procedure nursing care. Encourage the patient to drink fluids to promote elimination of radionuclide, to wash hands after voiding, and to flush immediately. Caregivers should wear ultrasonography. Purpose and procedure. Ultrasonography uses high-frequency sound waves to create an image of the liver, spleen, pancreas, gallbladder, and biliary system. The patient lies on a table. A technician applies gel to the abdomen and moves an instrument called a transducer over the abdomen. Images are projected onto a screen. It is not painful. Patient preparation. The patient may be NPO for 8 to 12 hours before the procedure. Post-procedure nursing care. No special care is required. Magnetic resonance imaging, MRI. Purpose and procedure. MRI creates cross-sectional images of the liver and other organs without radiation. MRI is a painless, non-invasive procedure, but the machine is noisy. The patient must remain still on a narrow surface. Patient preparation. All metal must be removed before the MRI. Older MRI devices are circular and surround the body like a tunnel. Closing the eyes reduces claustrophobia. Post-procedure nursing care. No special care is required. Liver biopsy. Purpose and procedure. A biopsy removes a small specimen of liver tissue for examination. Patient preparation. Baseline vital signs and blood coagulation should be obtained. Post-procedure nursing care. With all liver biopsies, do the following. Monitor vital signs for indications of bleeding, tachycardia, tachypnea, restlessness, hypotension, and pneumothorax, dyspnea, tachycardia. Needle biopsy. Purpose and procedure. The specimen is obtained by inserting a special needle into the liver through the abdominal wall. Patient preparation. The patient is positioned supine with the right arm behind the head. Post-procedure nursing care. Check the pressure dressing for bleeding. Position the patient on the right side as ordered. Open biopsy. Purpose and procedure. An open biopsy is done in the operating room. An incision is made and a tissue sample is obtained under general anesthesia. Patient preparation requires standard preoperative procedures. Informed consent must be obtained from the patient. Post-procedure nursing care. Monitor for bleeding. Position as ordered. Cholangiopancreatography. Endoscopic retrograde cholangiopancreatography, ERCP. Purpose and procedure. Medication is used to suppress the gag reflex. A flexible endoscope is passed after injection of dye. The study permits visualization of pancreatic, hepatic, and common bile ducts as well as the ampulla of Fada. It is used to diagnose pancreatic disease. Study take 30 to 60 minutes. Patient preparation, dye precautions, NPO for 8 to 12 hours. Post-procedure nursing care, dye precautions. Advise warm gargles or an ice pack to the neck for a sore throat. The patient may have belching and bloating. Immediately notify the physician of severe pain, fever, dyspnea, and hematemesis. NPO until gag reflex returns. Discuss pancreatitis and nursing care and patient teaching. Pancreatitis is inflammation of the pancreas. It may be acute or chronic. Chronic pancreatitis may follow the acute condition but often develops independently. Pancreatitis is most often associated with alcoholism or obstruction of the pancreatic duct by a gallstone. A high-fat diet and cigarette smoking may play a role as well. In addition, chronic pancreatitis is sometimes associated with cancer of the duodenum or pancreas. With pancreatitis, digestive enzymes are activated by some unknown mechanism and begin to digest pancreatic tissue, a process called autodigestion, fat, and elastic tissue in blood vessels. Pancreatic fluid may leak into the surrounding tissues. The effect of this escaped fluid has been compared to an internal chemical burn, and it can be devastating. Chronic pancreatitis is often related to alcohol abuse. It is usually characterized by obstruction of the pancreatic duct, leading to progressive destruction of the pancreas. Abdominal pain is the most prominent symptom of pancreatitis. The abdomen may be tender and distended. Bowel sounds may be absent. Cyanosis or greenish discoloration of the abdominal wall, the flanks, and the area around the umbilicus may be present. Hypotension is a late sign. In addition, patients with chronic pancreatitis may develop diabetes mellitus and malabsorption with steatorrhea. Cyanosis or greenish discoloration of the abdominal wall, the flanks, and the area around the umbilicus may be present. Enzymes released into the abdominal cavity increase capillary permeability, permitting protein-rich serum to leak from blood. Complications: kidney failure. Acute pancreatitis may cause kidney failure, which can be treated with dialysis if the kidney failure is severe and persistent. Breathing problems. Acute pancreatitis can cause chemical changes in your body that affect your lung function, causing the level of oxygen in your blood to fall to dangerously low levels. Infection. Acute pancreatitis can make your pancreas vulnerable to bacteria and infection. Pancreatic infections are serious and require intensive treatment, such as surgery, to remove the infected tissue. Pseudocyst. Acute pancreatitis can cause fluid and debris to collect in cyst-like pockets in your pancreas. A large pseudocyst that ruptures can cause complications such as internal bleeding and infection. Malnutrition. Both acute and chronic pancreatitis can cause your pancreas to produce fewer of the enzymes that are needed to break down and process nutrients from the food you eat. This can lead to malnutrition, diarrhea, and weight loss, even though you may be eating the same foods or the same amount of food. Diabetes. Damage to insulin-producing cells in your pancreas from chronic pancreatitis can lead to diabetes, a disease that affects the way your body uses blood sugar. Pancreatic cancer. Long-standing inflammation in your pancreas caused by chronic pancreatitis is a risk factor for developing pancreatic cancer. Medical diagnosis. The most important diagnostic findings in acute pancreatitis are elevated serum amylase, serum lipase, and urinary amylase levels. When the kidneys clear amylase more rapidly than they clear creatinine, acute pancreatitis is strongly suspected. Other findings with acute pancreatitis are elevated WBC count, elevated serum lipid and glucose levels, and decreased serum calcium level. Ultrasonography and ERCP may reveal to rule out other disorders that might be causing the patient's symptoms. Tests for chronic pancreatitis include the secretin stimulation test and fecal studies in addition to the tests used for acute pancreatitis. Findings consistent with chronic pancreatitis are decreased volume and bicarbonate concentration of pancreatic fluid, low serum trypsinogen, and high fecal fat content. Imaging procedures reveal the structure of the pancreas and the pancreatic duct. Medical treatment. The patient with acute pancreatitis is usually allowed nothing by mouth, NPO. This removes the stimulus for secretion of pancreatic fluid. If the patient is vomiting or if an ileus is suspected, a nasogastric tube NG inserted and connected to suction. Intravenous fluid are ordered to restore and maintain fluid balance. Urine output is monitored and should be at least 40 milliliters per hour. A nasogastric or jejunal feeding tube or TPN may be needed to provide adequate nutrients. Once food is permitted, the patient is usually started on a bland, high-carbohydrate, low-fat diet divided into frequent, small meals. Because the inflamed pancreas is susceptible to infection, some physicians order prophylactic antibiotics. Drug therapy. Drug therapy for pancreatitis commonly includes analgesics, antispasmodic agents, anticholinergic agents, and gastric acid inhibitors. Pain control is a major problem with pancreatitis. Opioids, example, morphine, traditionally have been avoided because they are thought to cause more spasm in the pancreatic ducts. However, Dilaudid or morphine is gaining favor because the pain relief lasts longer, and spasms can be managed with the antispasmodic drugs such as nitroglycerin. Anticholinergic agents decrease secretions, which also can reduce spasms and pain. Reducing the secretion of gastric acid decreases the stimulus for pancreatic secretions. With chronic pancreatitis, acetaminophen or ibuprofen is tried initially for pain control. If these non-opioid agents do not provide relief, hydrocodone may be prescribed. Assessment. When a patient has acute pancreatitis, it is especially important to report signs of hypovolemic shock, restlessness, tachycardia, tachypnea, hypotension, and decreased urinary output. The abdomen should be inspected for discoloration, distension, tenderness, and diminished bowel sounds. The flanks also should be examined for discoloration. In addition, the patient's mental status should be monitored. Altered mental status may be the result of metabolic imbalances. The alcoholic patient may develop confusion and agitation because of alcohol withdrawal. Nursing diagnosis. Acute pain. Describe the patient's pain and provide ordered analgesics and antispasmodics promptly. Reposition the patient for comfort. Deficient fluid volume. If ordered, insert a nasogastric tube and connect it to suction. Administer prescribed intravenous fluids. Monitor the patient's fluid status by measuring vital signs, intake and output, and weight. Signs of fluid volume deficit include tachycardia, hypotension, dry skin, concentrated urine, and decreased urine output. The physician should be informed if the urine output falls below 40 milliliters per hour. Risk for infection. Necrosis of the pancreas and surrounding tissue provides a site for infection. If a surgical procedure is done, there also is risk for wound infection. Inform the physician of fever, purulent drainage, or separation of wound margins. All signs of infection. Take special care to maintain asepsis during wound care. Administer antibiotics as ordered. Impaired gas exchange. Because the acutely ill patient is inactive, secretions may pool in the lungs. Poor lung expansion and inactivity combine to invite pneumonia and atelectasis. Monitor for tachypnea, dyspnea, and abnormal breath sounds. Measures to prevent pulmonary complications in the patient with pancreatitis include frequent turning, coughing, and deep breathing. The semifowler position promotes lung expansion. Imbalanced nutrition, less than body requirements initially. The patient will be NPO because food and fluids stimulate pancreatic fluid secretion. When oral intake is resumed, small feedings of a bland, high-carbohydrate, low-fat diet are provided. Spicy foods, caffeine, and alcohol should be avoided. TUN promotes lung expansion. The patient with chronic pancreatitis commonly requires pancreatic enzyme replacement taken with meals and supplemental vitamins. If the pancreas is severely damaged, insulin secretion will be deficient. The patient will have to be managed like a person with diabetes mellitus. Anxiety. Attempt to determine the reasons for the patient's anxiety. Some concerns can be alleviated by telling the patient what is happening and what to expect. Respond promptly to the patient's needs and offer comforting reassurance by checking on the patient frequently. During acute attacks, answer questions and give simple explanations. As the patient improves, implement your teaching plan. Patient teaching. Pancreatitis. Your prescribed diet, usually bland, high carbohydrate, low fat, will avoid stimulating your pancreas and will promote healing. At first, you may tolerate small, frequent meals better than large meals. Abstaining from alcohol decreases your risk of recurrence. Community resources such as Alcoholics Anonymous can assist if it is hard for you to abstain from drinking alcohol. Discuss drugs used to treat pancreatitis and discuss the case study, page 883. Opioid analgesics. Meperidine, Demerol, and morphine relieve pain. If morphine is ordered, an antispasmodic is usually ordered to prevent spasm of bile duct. Side effects: sedation, confusion, hypotension, nausea, vomiting, constipation. Monitor the patient's BP, pulse, and respiration. Assess bowel elimination. Observe safety precautions. Give antiemetics as ordered. NSAIDs and ketorolac, Toradol. Relieve pain. Headache, abdominal pain, GI bleeding, nephrotoxicity. Assess emesis and stools for blood. Monitor urine output. Smooth muscle relaxants, nitroglycerin. Relieve spasm, reduce pain. Headache, dizziness, flushing, tachycardia, hypotension. Monitor the patient's BP and pulse. Use special containers and tubing for administration. Antispasmodics, propantholine bromide, probanthine. Decrease bicarbonate and pancreatic enzyme secretion. Tachycardia, dry mouth, constipation, urinary retention/hesitancy, drowsiness. Administer the drug 30 minutes before meals. Do not give medication within 1 hour of antacids or antidiarrheals. Observe safety precautions if the patient is drowsy. Provide good mouth care and monitor stools. Antacids neutralize gastric acid, indirectly decreases production of pancreatic secretions. Constipation with aluminum and diarrhea with magnesium. Monitor the patient's electrolytes. Give the drug 1 hour apart from other oral drugs and on an empty stomach. Have the patient chew the tablets and drink a full glass of water. Shake liquids well. Carbonic anhydrase inhibitors, acetazolamide, Diamox. Reduced bicarbonate concentration in pancreatic secretions.
Rash, drowsiness, nausea, vomiting, renal calculi, hypercalcemia, aplastic anemia, leukopenia, seizures, hypokalemia.
Encourage the patient to drink 2,000 to 3,000 milliliters fluid per day unless contraindicated. Give the drug with food to decrease GI distress. Observe safety precautions. Monitor electrolytes and blood cell counts. Histamine 2 receptor blockers, cimetidine, Tagamet, ranitidine, Zantac, famotidine, Pepcid. Decrease production of HCI so that pancreatic enzymes cannot be activated. Confusion, nausea, diarrhea, constipation, drowsiness, headache, rash, agranulocytosis. Administer with or immediately after meals. Discourage smoking, which counteracts drug benefits. Observe safety precautions. Report a sore throat or fever to the physician. Cimetidine is not recommended for older adults due to risk of confusion and interaction with many other drugs. Vitamin and mineral supplements. Supplement poor dietary intake or impaired absorption, calcium tratase, hypocalcemia. Potential for overdose of fat, soluble vitamins, and calcium. Calcium potentiates cardiac glycosides. No special care required. Adrenocortical steroids. Decrease inflammation. Fluid retention, hypokalemia, hyperglycemia, hypocalcemia, decreased resistance to infection, mood swings. Monitor the patient's BP, pulse, and blood glucose. Assessment for edema. Protect the patient from infection. Explain that emotional and personality changes are temporary. Pancreatic enzymes, pancreatin pancrelipase, cotasm, biocase, pancrease. Supplement normal pancreatic enzyme secretion and aid in the digestion of fats, carbohydrates, and proteins. Goal is less frequent stools with lower fat content. Diarrhea, nausea, stomach cramps, abdominal pain. Give the drug with meals or snacks. Capsule contents can be sprinkled on food but should not be chewed. Mix powders with fruit juice or applesauce to mask the taste. Do not mix with protein foods. Have patients wipe their lips with a wet cloth to prevent skin irritation. Evaluate the drug effect by noting the number and consistency of stools. Hypoglycemic agents, insulin, oral hypoglycemic agents. Used when the pancreas is unable to produce sufficient insulin. Hypoglycemia. Replacement of fluids. The patient will be given fluids, usually intravenously, until rehydration. Replacement of electrolytes. Electrolytes are minerals in the blood that the tissues require to function effectively. Discuss cancer of the pancreas, nursing care and complications for the Whipple procedure and nutritional considerations. Find video of the Whipple procedure. Cancer of the pancreas. It is extremely serious. Pancreatic cancer quickly spreads to the duodenum, stomach, spleen, and left adrenal gland. Only 24% of people survive for 1 year, 4% will be alive after 5 years. The risk factors for pancreatic cancer include chronic pancreatitis and smoking. Other probable risk factors are a high-fat diet and exposure to certain toxic chemicals. Tumors may develop in the head, body, or tail of the pancreas. Signs and symptoms. It varies with the stage and location, but often includes pain, jaundice with or without liver enlargement, weight loss, and glucose intolerance. When located in the head of the pancreas, tumors typically obstruct the common bile duct, causing jaundice. If the patient seeks medical care early, the chance of survival is somewhat better. Other signs and symptoms may be weight loss, upper abdominal pain, anorexia, vomiting, weakness, and diarrhea. When the tumor is in the body or the tail of the pancreas, the patient may not have any symptoms until the disease is advanced. Then the liver, gallbladder, and spleen may be enlarged. Pressure on the portal veins may cause esophageal and gastric varices that bleed easily into the GI tract. Pressure on nerves may cause back pain. Medical diagnosis. The most useful diagnostic tests and procedures when pancreatic cancer is suspected are transabdominal ultrasound, CT, MRI, ERCP, magnetic resonance cholangiopancreatography, MRCP, and endoscopic ultrasonography. Blood studies and other imaging procedures can be helpful as well. Blood values associated with pancreatic cancer include elevated serum amylase, lipase, bilirubin, and enzyme levels. The tumor marker CA19-9 is usually elevated with pancreatic cancer. Percutaneous transhepatic cholangiography and ERCP allow the physician to detect obstructed pancreatic ducts as well as to take samples of pancreatic fluid and tissue. Medical treatment. Treatment depends on the location and extent of the malignant tissue. Radiation therapy and chemotherapy may be advised either preoperatively or postoperatively. Radiation does not appear to improve therapy but may reduce pain. Some surgeons believe that a combination of surgery, radiation, and chemotherapy may be the best approach. Surgical treatment. If the tumor is confined to the head of the pancreas, surgery may be an option. The most common are side-to-side pancreatojejunostomy, caudal pancreatojejunostomy, and radical pancreaticoduodenectomy, Whipple procedure. Sometimes surgical procedures are done primarily to relieve obstruction and improve patient comfort. Opioid analgesics are ordered for pain management. At times, a jejunostomy tube is placed below the obstruction so that the patient can be given tube feedings. Nursing care. With pancreatic cancer, pay particular attention to GI function, pain, and emotional state. If surgery is planned, assess the patient's knowledge about preoperative and postoperative care. Acute pain related to obstruction, extensive malignancy, assess and record pain severity, nature, and location. Opioid analgesics are usually needed for severe pain management. Non-opioids may be effective for mild to moderate pain. Radiation therapy and chemotherapy can reduce pain by shrinking the tumor. A cardiac plexus nerve block can be done during surgery or percutaneously to provide pain control for several months. Other options include PCA pump and epidural opioids. Distraction, imagery, and cutaneous simulation can also be used. Imbalanced nutrition, less than body requirements related to anorexia, nausea, vomiting, monitor the dietary intake and weight. If intake is poor, consult the dietitian. Small, frequent meals may be ordered. Pancrelipase tablets are needed if the patient has malabsorption. At times, a jejunostomy tube is placed and feeding is delivered through the pump. Feedings are usually started with dilute formula given at a slow rate. Both the concentration and rate are gradually increased. Inform the physician if the patient develops diarrhea. Some patients require TPN for adequate nourishment. Disturbed body image related to pruritus, inactivity, nutritional deficiencies, weight loss and jaundice alter the patient's appearance and may be distressing. Assist patients with grooming and encourage them to look their best. Complications of the Whipple procedure. Hemorrhage, intervention. Monitor vital signs for tachycardia and falling blood pressure. Assess for restlessness. Check dressings and drains for excess bleeding. Fluid and electrolyte imbalances, intervention. Assess for cardiac dysrhythmias, muscle weakness or twitching, and change in mental status. Monitor intake and output as well as tissue turgor. Check laboratory reports and notify the physician of abnormalities. Respiratory failure, intervention. Monitor respiratory rate and effort, skin color, and breath sounds. Circulatory failure, intervention. Monitor for dysrhythmias, tachycardia, and falling BP. Renal failure, intervention. Measure intake and urine output. Report output of less than 30 milliliters per hour. Assess for edema and maintain prescribed fluid intake. Hepatic failure, intervention. Assess for jaundice, fatigue, confusion, and digestive disturbances. Wound infection/dehiscence/fistulas, intervention. Assess dressing and drains for excess bleeding, foul odor, and purulent drainage. Check the patient's temperature for fever and note any elevation in WBC count. Hyperglycemia, intervention. Monitor blood glucose as ordered. Note drowsiness, thirst, polyphagia, and polyuria. Nutritional considerations. People with gallbladder disease should follow a low-fat diet because fat intake usually causes pain. For a person with hepatitis, the diet should be high in calories and vitamins with moderate to high protein and moderate to low fat. When the liver is damaged by cirrhosis, protein may be restricted to lower blood ammonia. In hepatitis and cirrhosis, carbohydrates, high protein, low-fat diet is recommended for pancreatitis. Pancreatitis patients must avoid alcohol and spicy foods that stimulate the pancreas. Review key points and meds to treat constipation and diarrhea in Watkins page 370 to 371. Medications to treat constipation. When peristalsis slows, constipation or infrequent, hard stools can result. Some medications that contribute to constipation are diuretics, which remove fluid from the body and thereby cause hard stools. One such medication is furosemide, Lasix. As a result, the colon reabsorbs too much fluid, the feces become hard, and the alimentary canal does not clear. Laxatives are a class of medications that can help relieve constipation by promoting bowel movements. Laxatives can help diagnose GI disorders by cleansing the bowel to allow observation of the intestinal walls during examination. These medications should not be used for losing weight because they could lead to a dependency on them to have a bowel movement and may also cause electrolyte imbalances. A cathartic is a stronger medication that facilitates fast emptying of the colon. Laxatives are classified as bulk-forming agents, osmotics, stimulants, or stool softeners. Bulk-forming laxatives. Bulk-forming laxatives such as psyllium, metamucil, increase bulk and water content of the stool because they resemble dietary fiber. This medication is available as a powder that can be added to liquid, as a capsule, and as a wafer to be eaten. Prunes and bran have the same effects. Bulk-forming laxatives are the best laxatives to take during pregnancy, and if needed on a routine basis, they absorb water and create larger, softer stools. These larger stools stimulate peristalsis and thus purge the body of feces. These laxatives take 12 hours to 3 days to work. Lubricant laxatives. Lubricant laxatives such as mineral oil increase the water-to-fecal mass to ease the passage of stool and are usually taken as suppositories. Lubricant laxatives are typically oily. They take 6 to 8 hours to work. Osmotic laxatives. Osmotic laxatives, given rectally, such as glycerin or sorbitol, exert an immediate action that draws water into the stool and irritates the bowel to increase peristalsis. The result is evacuation of stool, sometimes in the form of diarrhea, within 15 to 60 minutes. These laxatives are contraindicated in patients with hypertension, edema, or congestive heart failure because of the stress on the cardiovascular system caused by this rapid action. Milk of magnesia is a mild osmotic laxative, sometimes called a saline laxative. It increases the amount of water in the large intestine and usually works within 2 to 12 hours, depending on the dose. The salt ions in milk of magnesia can attract water molecules toward each other and thus lubricate the GI tract. Milk of magnesia is therefore a safe option for patients with hypertension, edema, or congestive heart failure. Stimulant laxatives. Stimulant laxatives stimulate peristalsis because they act directly on the intestinal mucosa and irritate the bowel. They are typically effective within 6 to 8 hours. Some examples include bisacodyl, senna, aloe, cascara sagrada, and castor oil. Side effects include cramping, diarrhea, flatulence, and nausea. Senna, aloe, and cascara sagrada discolor urine. Castor oil should not be used during pregnancy because of the risk for premature labor or during lactation because it may cause diarrhea in the infant. Stool softeners. Stool softeners decrease the consistency of stool by reducing surface tension and attracting water and fat to the stool to soften it and improve its passage through the colon. Docusate, colace, is a detergent stool softener. This type of laxative is typically used routinely in patients with limited mobility resulting from injury or chronic illness. Bowel evacuators. Bowel evacuators are cleansing solutions that are used to remove stool before diagnostic tests, such as colonoscopy. They are made as mixes similar to body fluids, so material held in the bowel is rejected. Typically, the patient is asked to drink 1 gallon of fluid mixed with a bowel evacuator within a 2 to 3 hour time frame. Side effects can include bloating, nausea, and fullness. Examples of bowel evacuants include polyethylene glycol electrolyte solution, Colite, Go Lightly, Moviprep, New Lightly, PEG 3350 with electrolytes, Trilite, and polyethylene glycol 3350, Glycolax, Miralax. Medications to treat diarrhea. The opposite of constipation is diarrhea, which is an increase in the frequency and fluidity of bowel movements. Almost all individuals have diarrhea at one time or another, but if it occurs over several days, the body can lose too much fluid and too many electrolytes. This loss can occur within several hours in small children and infants. Diarrhea is a symptom, not a disease. Certain chemicals, inflammation, infectious, and other medications can cause diarrhea. Anti-infective therapy frequently causes diarrhea. Anxiety and circulatory disorders can cause diarrhea as well. Stools of excessive volume and fluidity are more than just a bother. The cramping that frequently accompanies diarrhea can be very painful. Diarrhea can signal that the person has eaten spoiled or contaminated food and has an intestinal infection. In small children and the elderly, diarrhea can cause life-threatening loss of valuable fluid and electrolytes. Fortunately, several available medications, such as opioid-related antidiarrheals and absorbents, can help treat diarrhea. Opioid-related antidiarrheal medications are highly effective and are used for the most serious case of diarrhea. They work by inhibiting gill motility, decreasing peristalsis, and slowing the function of the GI systems, thus allowing more time for water to be reabsorbed through the intestinal wall. An example is loperamide, Imodium, which is taken orally and is available over the counter, OTC, as well as by prescription. Another example is diphenoxylate with atropine, Lomotil, which comes in tablet form and is available only by prescription because of the addictive qualities of this drug. Side effects include dizziness, dry mouth, agitation, numbness, drowsiness, and tachycardia. Absorbents. Absorbents, such as bismuth, Pepto-Bismol, or kaolin and pectin, kaopectate, are taken after every bowel movement to absorb toxins on bacteria and to coat the walls of the GI tract because the treatment focuses on the cause of the diarrhea. Medications may also include antibiotics, anti-inflammatories, or antiparasitics. The most common use of antibiotics for diarrhea occurs with traveler's diarrhea, exposure to contaminated water or food, often in less developed countries with poor sanitation infrastructure, leads to bacterial, viral, or parasitic infections. Ciprofloxacin, Cipro, ofloxacin, Floxin, and azithromycin, Zithromax Z-Pak, are commonly used antibiotics, depending on the destination of the traveler. Ulcerative colitis is an example of inflammation that causes diarrhea and is treated with anti-inflammatory drugs such as sulfasalazine, azulfidine, mesalamine rectal, Canasa, Rawasa, valsalazide, Colazole, and alsalazine, Dipentum. Review NCLEX and Evolve Questions and Medications to treat nausea and vomiting. Watkins p. 371 to 373. Medications to treat nausea and vomiting. Antiemetics. Nausea, although an uncomfortable feeling that vomiting is imminent, is not dangerous. Sometimes nausea is caused by unusual smells, pregnancy hormones, or emptiness of the stomach. Emesis, or vomiting, occurs when the patient ejects the contents of the stomach. Antiemetics decrease nausea and vomiting and are also used to treat motion sickness. Examples of antiemetics include phenothiazines such as prochlorperazine, compazine, antihistamines such as diphenhydramine, Benadryl, and meclizine, Antivert, phosphorated carbohydrate solution, Emitrol, and 5-hydroxytryptamine 3, 5-HT-serotonin, receptor antagonists such as ondansetron, Zofran. Phenothiazines. Phenothiazines mock dopamine receptors in the area of the brain that stimulates vomiting. Two examples, chlorpromazine, Thorazine, and prochlorperazine, Compazine, are used to control the nausea and vomiting that occur with chemotherapy and can be administered orally, by injection, or by the intravenous, route. In addition, prochlorperazine may be given as a rectal suppository. These drugs tend to produce sedation while treating the nausea and vomiting. These medications are available by prescription only. 5-hydroxytryptamine 3 receptor antagonists. 5-HT is more commonly known as serotonin. Therefore, These medications are known as serotonin antagonists and are commonly used to prevent and treat the nausea and vomiting associated with chemotherapy. They block the chemical serotonin, which is produced in the brain and in the stomach. Examples of this class of medications include dolasetron, Anzimet, ondansetron, Zofran, granisetron, Kytril, and palonosetron, Aloxi. These medications are all administered either orally or by the route. Additionally, Zofran may be given as an injection. These medications are available by prescription only. Antihistamines. The action of antihistamines in decreasing nausea and vomiting is unclear. It is believed that these medications block signals to the brain's movement center. Therefore, they tend to work best on the names associated with motion sickness. Dramamine, dimenhydrinate, diphenhydramine, Benadryl, Meclizine, Antivert, Bonini, and promethazine, Adgan. Phenergan, Promethicon, are examples of this class of drugs used for nausea and vomiting. All of these medications are available to be taken orally, and dimenhydrinate, diphenhydramine, and meclizine may be purchased OTC. Dimenhydrinate, diphenhydramine, and promethazine may also be administered by injection or by the route. Promethazine may also be given by rectal suppository. Anticholinergic medications. Anticholinergic medications block the effects of the neurotransmitter acetylcholine. It is thought to act on the brain's chemoreceptor trigger some in an area of the medulla. This zone initiates vomiting and can be stimulated by blood-borne medications or hormones. Trimethylbenzamide, Benzicot, Tigan, Ticon, is an anticholinergic that can be given orally, rectally, or by IM injection and is available by prescription only. Another prescription anticholinergic medication is scopolamine, Maldemar Scopase, Transderm Scop, which can be given by the IM, or subcutaneous route for nausea and vomiting. In addition, scopolamine can be used as a transdermal disc placed behind the ear before exposure to a motion sickness-causing event. Cannabinoids. These are manufactured forms of cannabis. Marijuana is the herbal form of cannabis. An example of a cannabinoid is Nabil-1, Sesamet, and it works by affecting the area of the brain that controls the nausea and vomiting impulses. This medication has a high level of addiction possibility and therefore should be prescribed only when other antiemetics are unsuccessful for the patient receiving chemotherapy. In addition, the patient may suffer from altered thinking and thus should take this medication with care. Sesamet is taken orally before the start of chemotherapy and for a period of time during and after each chemotherapy dose. This drug and marijuana are controlled substances. According to the National Conference of State Legislatures, as of August 2017, a total of 29 states, the District of Columbia, Guam, and Puerto Rico now allow for comprehensive public medical marijuana and cannabis programs. There are varying laws in each state as to who can grow and dispense marijuana and what medical conditions are eligible. There are also some states that allow only cannabis oils with low THC and not the actual marijuana plant. It is important to check the most up-to-date regulation in your state if you are involved with patients that would benefit from medical marijuana. Review worksheet and medications to treat GERD and peptic ulcers. Watkins, p. 374-376. Heartburn, burning sensation when acid damages esophagus. Pain near the heart, not involving it. Antacids, decrease hydrochloric acid in the stomach. Create more alkaline environment, protects mucosa. Not readily absorbed and don't alter body pH, except sodium bicarbonate. Contain aluminum, calcium, magnesium, sodium, or a combination. HCP chooses best components based on individual patient. Must be taken before food, tablets taken with water or milk. 30 minutes to 3-hour onset of action. H2 receptor blockers 1 hour before or 3 hours post-meal. Long-term use can mean increased acid secretion. Changing gastric acid affects absorption of other meds. Proton pump inhibitors reduce acidity of stomach by binding to stomach enzymes. Protect stomach for longer period of time than antacids. Inhibit hydrogen and potassium acid. Short-term treatment of GERD and peptic ulcers. Side effects: abdominal pain, headache, constipation, diarrhea, nausea. X. Esomeprazole, Nexium, Lansoprazole, Prevacid, Omeprazole, Prilosec, Pantoprazole, Probnix, Rabeprazole, Acifex. Given by mouth, mostly by prescription. All may be given except pantoprazole. Gastric stimulants / prokinetic agents decrease esophageal sphincter pressure and increase gastric emptying, improves peristalsis. Reduces time drug is in stomach, reducing risk of aspiration pneumonia or choking. Antiemetic effect. X. Metoclopramide, Reglan, primarily by 4-root but may be IM or PO. Side effects: drowsiness, restlessness, headache, dry mouth, menstruation changes, diarrhea. PUD. Secretion of too much HCl breaks down stomach mucosal layer, leads to peptic ulcer. Same can occur in duodenum. High risk factors: type O blood, cigarette smokers, H. pylori infections, poor coping with stress. Meds: alcohol, caffeine, corticosteroids, aspirin, NSAIDs. H. pylori, 75% of gastric ulcers, 90% of duodenal ulcers. Milk is one of worst treatments to recommend, allows growth of H. pylori. Antibiotics fight H. pylori, giving ulcer chance to heal. X. Amoxicillin, Amoxil, Trimox, clarithromycin, Biaxin, metronidazole, Flagyl, tetracycline. Never used alone, combination of 2 antibiotics. Important to complete entire 7 to 14-day regimen. Bismuth compounds stop H. pylori from sticking to mucosa. Mucosal protectants cover and protect ulcer, promote healing. Oral medications taken on empty stomach. Sucralfate, carafate, aluminum hydroxide and sulfated sucrose. Like bandage protecting wound from dirt and injury. Side effects: constipation, vitamin deficiency. Prostaglandins, hormone-like substances, contract and relax smooth muscle, moderate inflammation, control blood pressure. Misoprostol, Cytotec, inhibits gastric acid secretion. Decrease exposure of mucosa to HCl by keeping food in stomach and reducing acid. Also treat GERD, ulcerative colitis, diverticulitis, biliary spasm, IBS. X. Dicyclamine, Bentyl, glycopyrrolate, Robinol. Prescription only. May be administered orally or IM. Glycopyrrolate can be given H2 receptor antagonists block histamine from binding to parietal cells and prevent secretion of HCl acid. X. Cimetidine, Tagamet, Famotidine, Pepcid, Nizatidine, Axid, Ranitidine, Talidine, Zantac. By prescription or OTC. Cimetidine, famotidine, ranitidine initially may be 4, oral form, given once acute phase treated. Ranitidine may be given IM, nizatidine only PO. Taken with or without food, most effective 30 minutes before meals. Should not be given within 1 hour of antacid. Antacid inhibits absorption. Side effects: nausea, vomiting, diarrhea, dry mouth, dizziness, weakness, headache, muscle cramps. Proton pump inhibitors reduce acidity of stomach.